Hello, hi. I'm Dr. Gokula Kumar, visiting Consultant Radiation Oncologist to Penang Adventist Hospital. I've been here for the past 4 years. And a short introduction, I was trained as a radiation oncologist at National University Hospital of Singapore and the Alfred Hospital in Melbourne, where both together I spent a good 6 years of my career. So I do all range of radiotherapy treatment, especially the advanced radiotherapy techniques. During my experience in Alfred Hospital in Melbourne, I worked in the Melbourne Prostate Institute for 2 years. So I also involved in all the advanced brachytherapy technique for prostate, such as interstitial brachytherapy and high dose rate brachytherapy of the prostate. So my special interest is radiotherapy as a trained radiation oncologist. So the radiotherapy today is very different from what it was 10 or 20 years ago. Even in the last 4-5 years, there is a lot of advancement in the radiotherapy methods, techniques, and the skills of the radiation oncologists who perform this. So we know for sure that even from time immemorial that increasing the dose of radiotherapy will increase the control of the tumor and will improve the outcomes by clearing the tumor. The word clearing I use here is something like surgically you excise and take out the tumor. Radiotherapy can achieve that. But the problem had been because we could not deliver very high dose of radiation. The reason being the toxicities to the structures that surround the target. So today we have advanced radiotherapy techniques whereby we can focus the dose very well to the tumor while sparing the tissue surrounding it. And these techniques we may have heard, people would have heard, like volumetric arc radiation therapy, stereotactic radiotherapy, stereotactic body radiotherapy, and sometimes we even insert spacers into the organs thus to push the normal structure away from the tumor so that we can deliver very high dose of radiation to the tumor. And also there is this interstitial brachytherapy, which my special interest in, where we put the needle directly into the tumor and we deliver very high doses. We call it the ultimate lethal doses of radiation, where any tumor can be killed. So today we have reached a time when there are many tumors or cancers in the body where we can achieve results that are equivalent to surgery just with radiation, or sometimes even better than surgery, by focusing very high dose to the target. Things like stereotactic radiotherapy and stereotactic body radiotherapy, we started by using that in the brain, where we target the tumor in the brain. Now we are applying it to the rest of the body, like the liver, the pancreas, the spine, the lung, and prostate, and multiple other sites. So with these advanced techniques, a meticulous job, there's a steep learning curve. We have the radiotherapy today has come to an age where the outcomes are very different, and the tumor cure rates, here I use the word cure rate, that means tumor local control rates are much better than what it used to be. Okay, when we talk about cancer that can be treated with radiotherapy, it is estimated that nearly 60% of all patients who develop malignancy will need radiotherapy at some point in their life. But when we talk about the advanced radiotherapy techniques, this is a niche area where special training is needed. And what we do at Adventist too, we do stereotactic radiotherapy to the brain. We do a stereotactic body radiotherapy. That's the same concept, but we do it outside the brain in areas like lung, liver, spine, and pancreas, like what I mentioned earlier. Okay, a wide range of tumors can be treated with this advanced technique, especially when the tumors metastasize. That means it spread to the liver or lung when there's a limited disease. But it is best for the patient to meet up with the radiation oncologist and discuss about this, because the indications are quite complex in cancer management. Okay, when we talk about the advanced radiotherapy techniques in cancer management, like what I mentioned earlier, there used to be a time when radiotherapy were not able to deliver high doses. So many patients were subjected to surgical resection of tumors when they could have gone through an advanced technique where it's a 1 or 3 day treatment. We could have controlled the tumor. So it is a combination treatment with chemotherapy where we don't delay the chemotherapy. If patient go for surgery, they may need like 2 or 3 weeks up to a month to recover. So these are the things where the advanced radiotherapy technique comes into picture. There are also patients who are unfit for surgery, or patients disease which is not resectable. This is another area where the advanced radiotherapy technique is gaining momentum. So if we look at it, around 10 years ago we used to say, oh, you can't operate a tumor, it is the end of the story, because radiotherapy is palliative. That means it's just to control the symptom. But today, with the advanced technique, we came to a time whereby we can deliver high doses of radiation to clear the tumor, like what I mentioned earlier, probably matching the results of a surgical resection. Okay, these procedures depends on which part of the body that we are treating. If we are treating the brain, then we will do a special mask. This is called a double mask, which is very rigid to ensure that the head doesn't move while we are delivering the radiotherapy. So with the mask on, we will do a CT scan, and we call it the CT simulation, and we will plan on it with the advanced planning method like what we have at Adventist, the volumetric arc therapy. And for sites like prostate, sometimes we insert a gel between the prostate and rectum to space the rectum away from the prostate. If liver, we have to do what we call a gating scan. So what happens is liver and lung and all the abdominal structures, when we breathe, they can move up and down like 2 to 3 centimeters. So we need to account for the movement, because we do not want to treat in a wrong area and wrongly target. So for this, what we call it a real-time CT scan or 4D CT scan, where we can see the movement of the internal organs and tumor and target it precisely. So these are complex techniques, and as I mentioned again, it needs there's a steep learning curve. And yes, we do it at Adventist. We have been doing it for the past 4 years. The advantages of these advanced radiotherapy techniques is that probably we can spare the normal tissue or the organs better than what we could have done long before. And as we increase the dose of radiation that is delivered to the tumor, the control of the tumor, so tumor control rate, that means what we treat with the radiation, that tumor can disappear. So the control of the tumor increases. So these are the advantages. And if you look at like the stereotactic radiotherapy to the liver and brain, the other option the patient has is to undergo surgery. It is still an area of contention whereby we are not promoting the radiotherapy as the only option, but it is another option that we can be given to patients, especially those who do not wish to undergo surgery. And the results at this point of time, the evidence shows that it's nearly equivalent to the surgical resections. Yeah, these treatment durations take longer, but it's not the treatment itself usually is longer, it is the planning process that is longer, because we need to do a real-time CT scan or we do a special mask. The first day when you come for treatment, when we do the scans, we need to spend a longer time, probably an hour or two. But then the treatment itself, if a standard radiation takes around 5 to 6 minutes, the advanced techniques takes around 10 to 15 minutes. So I don't see the treatment to be a major issue, but the planning process, yes. When we speak about radiation treatment, it is not known to many people. Even many doctors too are very unsure of what we do and what we can offer. So it is a good idea for a patient who is diagnosed with the cancer, if they want to consult a radiation oncologist and to find out whether there are other treatment options. For example, when we talk about prostate cancers, radical prostatectomy or robotic radical prostatectomy is an option, but at the same time, prostate treatment using the radiotherapy, either the advanced technique like VMAT, the volumetric arc radiotherapy, or SBRT, interstitial brachytherapy to the prostate is also an option. And the results had shown that between the surgical arm and the radiation arm, probably there's a different toxicity profile, but the outcomes of the disease is equivalent. So it is always good for a patient who is diagnosed with cancer to consult a radiation oncologist to find out what are the options available. And there are newer advanced techniques like interstitial brachytherapy, where we put needles directly into the tumor. I do this advanced interstitial brachytherapy to the tongue, to the liver, and to rectum and many other sites where I put the needles into the tumor to directly radiate, which is much more focused. However, I practice this at my other practice center that I currently work at, University Science Malaysia. We will be bringing this technology to Adventist very soon, the interstitial brachytherapy, so that more patients can benefit. So you can see things like cancers of the tongue and everything, whereby we need to go through a total glossectomy, which means you remove the whole tongue. Today we can give another option to patients by putting in the needles, interstitial brachytherapy, and combining it the VMAT or IMRT treatment, the intensity modulated radiation therapy. We can give them an option to spare the tongue and probably can continue living with life with lesser morbidity than a radical surgery.